So I'll be talking to you about ovarian cysts, and as I mentioned, it's based on the college guidance strategy module and a TOG article. Next slide then, thank you. So we've already established that a cyst is a fluid-filled sac which is 3 centimetres or more. Can you get on to the next slide, Sophie? Has it frozen again?
Which slide are you wanting?
The next one, just the background.
Oh, sure. 1 sec. That should be it.
Possibly being a bit slow.
I think it's an issue when you're clicking on the play PowerPoint to make it go big. We're just stuck on the original screen.
Do you want me to just do it this way?
Yeah.
Okay, great. So it's the 4th most commonest reason for hospital admissions. Up to 10% of women will need surgery at some time during their lifetime. And premenopausally, most are benign, but obviously the older you get, they do become, there's an increased risk of malignancy. Can everyone still see the presentation, or has it gone?
Gone.
It's gone, I'm afraid.
Oh. I don't know why. Oh.
Yes, it's back. Thank you. Okay, let's go on to the next slide. Oh, sorry, I was just saying about polycystic ovarian syndrome. That's what I was asking. What do we think? Does it fit the bill? Doesn't fit the bill? You'll get calls from A&E saying we've got this, I don't know, 18-year-old, 26-year-old known to have polycystic ovarian syndrome. She's coming with lots of pain, and we think it's something to do with the polycystic ovarian syndrome. What are you going to say?
By the definition of the cyst, polycystic ovary cysts aren't actually cysts because they're too small.
Yes, it's a complete misnomer, isn't it? It should be called polyfollicular syndrome. And it's really annoying because women imagine they've got these huge cysts sitting on their ovaries and they're walking around with these huge cysts, but actually no, it's completely misleading. And they don't cause pain. The polycystic ovaries don't cause pain, do they? And as you say, they're just small follicles which have arrested in their development. So just, obviously I know it's something that you guys know, but just sometimes you need to use that piece of information when you're getting these inappropriate referrals. So when we're taking a history from our patients, you want to take history related to any potential symptoms. So symptoms can be related to any acute exacerbation. So usually any pain symptoms. So you want to obviously take your pain history to find out about that. And then you also want to take collateral symptoms, which may or may not suggest the risk of malignancy. So things such as any distension, changes in their appetite, changes with their bowels or urinary habits and things. And then you also want to establish that any risk factors, again, for malignancy. So primate, multip, any other cancers, any family history of breast or ovarian cancers. That's all basic stuff that we all know. Next slide. So this is a table which summarises what you may find in someone who presents on examination, things to look out for. Now, I have to say I don't agree with all of these bits. Again, it's from the TOG article or somewhere, or one of those 3 that I've mentioned. But someone that's got a hemorrhagic cyst or cyst rupture, temperatures generally normal, slightly raised. Torsion, I don't know if you guys have had much experience with torsion, but actually to say that it's significantly raised, I'd raise an eyebrow to that. Occasionally it might be raised, but significantly not so much, and it's usually a bit of a mild pyrexia. Pulse, you'd expect them to be tachycardic because of pain. Obviously there could be an element of bleeding as well. Blood pressure generally is fine. If it's torsion and the ovaries become necrotic, obviously patient can become septic and the blood pressure can be compromised. When you examine them, focal or generalized tenderness with a hemorrhage or cyst rupture. But actually, if there's hemorrhage, there's blood in the peritoneum, you might find more generalized discomfort because of the peritoneal irritation. And then on VE, there'll be similar findings. So cervical excitation, adnexal tenderness, maybe unilateral if it's just a cyst on one side, which hasn't necessarily ruptured, or just bilateral non-specific pain. So examination, you'll find a sore tummy, you'll find something on vaginal examination, but it doesn't help to differentiate what the underlying pathology is. But obviously if it's a normal examination, that's reassuring. Next slide, please. So your differentials, see, this is annoying. In my slide, it would have come up after I'd asked you guys, but obviously these are all the differentials that you're thinking about, because this is someone that's presented. So it's a female, obviously, unless they're menopausal, or the female childbearing age. What could be the different reasons for her having unilateral or just generalized lower pelvic pain? So you obviously have to think about ectopic pregnancy, appendicitis, PID, any abscess, diverticular disease, any urinary UTIs or stones, and fibroid degeneration as well. In terms of investigations, always do a urine pregnancy test. Always, always, always. This is something that's still missed by A&E. Remember, if they can't provide you with a sample, then, I mean, if they're able to, we can wait. Obviously, just get them to drink, but don't ever forget you can do an in-out catheter, especially if somebody's very sick. General bloodings, general blood tests as well. What do we think about doing the CA1-2 Is it helpful or not helpful?
I think it depends on how it looks on the ultrasound. If it looks benign and they're young, then I think it's not indicated. Okay, any other thoughts?
I agree. I think sometimes it's misleading and causes undue anxiety when it's interpreted incorrectly. Then
so I'll come on to that in a couple of slides time, but you've obviously got your urine pregnancy test, your blood test. Always dip the wee. Is there another reason for their pain? STI screen if it's indicated, and then obviously you're going to do an ultrasound scan. Next slide, please. So differentials, again, it's this is being more specific. So the first differential was just of pain. This is differential of potential adnexal masses. This is from the Green Top guidelines. So your benign ovarian masses. So they could be functional cysts. So something like a corpus luteum, or a follicle. It could be an endometrioma, cystadenomas, or a teratoma, which is obviously, what's the teratoma? What's the mature teratoma?
Dermoid cyst.
Dermoid, yes. I don't know why we say mature, but there we go. And then 10% of women will have a non-ovarian mass. So these could be paratubal cysts, a hydrosalpinx, abscesses, as I mentioned, and other things. So appendiceal abscess, diverticular abscess, pelvic kidney, and such like. We're not going to cover any of the cancer stuff, although I am going to talk about RMI briefly, but that will be something, all the cancer stuff we will cover it in a separate session next year. Next slide. So tumour markers. So this is direct from the Green Top guidelines. The CA1-2 does not need to be done in premenopausal women if the ultrasound shows that it's a simple cyst. So as was it Josh who mentioned that? So that's CA1-2 is not helpful. And sometimes you'll find GPs do this a lot in Reading, I don't know elsewhere, but they've unhelpfully done a CA1-2 and the problem is when you've got a raised result, you've got to do something with it. But ideally, you only do the test if it's indicated. So CA1-2 simple cyst, premenopausal, not indicated. Obviously, if it looks like a complex cyst, then it can be helpful. Other tumour markers that are recommended, and these are for women who are under the age of 40, alpha fetoprotein, HCG. So under 40, complex mass. Because of the possibility of germ cell tumours, and in America they also do an LDH, although I think here that seems to be the tendency as well, that we will do all of those tumour markers. If the results are normal, that's reassuring. If any of them are high, then obviously it needs to be looked into further. Next slide. So this is more about CA125. I'm sorry, that's come out so small, so that's a lot of information. So it's saying the same as what I've said already, that routine CA125 in premenopausal women, it's got very poor specificity. So as Lydia rightly said, it can cause undue anxiety. And it's also unreliable in differentiating benign from malignant disease. So again, it's annoying, the answers are all there. But remember, CA125, it's non-specific. It's only raised in about 50% of epithelial cell tumours arising from the ovary. It may be normal even in early disease, and actually it can be raised in benign disease such as fibroids, endometriosis, adenomyosis and pelvic infection. And basically anything that irritates the peritoneum can cause the raised CA125. So that shows you how unhelpful it is. So it should only be done in the right setting. And also if the patient's had a period recently as well, again, that can be a reason why it may be raised. So you must always think about this in someone that's premenopausal. But it does say just in the middle paragraph there that if it's less than 200, so you would want to look for other causes, as I've explained. If it's more than 200, well, that is significantly raised, so you would want to have it looked into further. So it's advised to refer the patient to the MDT. And obviously, if it's rapidly rising, that's again worrying. So sometimes, you know, if you've got a raised CA125, you're not just going to say, oh, you're premenopausal, we're just going to ignore it. So just repeat it, look at what the trend is like. If it's rapidly rising, that's worrying. Next slide. So ultrasound, you should always do a TA ultrasound followed by a TV ultrasound if the patient consents to it. And a TV scan is more sensitive basically compared to a TA scan. That's what that is saying. And you would have thought that colour Doppler might be helpful, you know, to distinguish between benign and malignant disease, but not necessarily. It doesn't improve any diagnostic imaging, diagnostic accuracy. And in terms of further imaging, obviously, if it looks benign, then you don't need to. But if it doesn't look benign, it goes without saying that you would need to do further imaging, which is usually done by MRI. Thank you. So this is the only slide that I'm going to talk about in terms of malignancy, because I think it's something that everyone gets excited about. But how can you determine if a mass looks malignant or not on scan? So what we'll all be familiar, you guys are probably familiar with both actually, but IOTA is still relatively new. But the bog standard is using RMI, the risk of malignancy index. It's the most commonly used tool. You've got a little calculation there if you really want to see. But it combines the CA125, the menopausal status, so if they're pre or post-menopausal, and the ultrasound score. And this newer classification, the IOTA classification, it's got increased sensitivity and specificity. However, having said that, we still do use RMI when it comes to assessing the risk of malignancy. You can read the rest of that, that's fine, thank you. I think there might be a bit more on the next slide. Yes, so a bit more about from the IOTA group, just about the B rules and the M rules, so benign disease, malignant disease. You guys probably don't need to know it in depth just at the moment, especially for part 1 exams, I would have thought, but it's something that you need to become familiar with, but you can read that in your own time. So next slide. Management. So it depends on the underlying cause. Obviously, you know, someone's got a 4 centimetre simple cyst. Does it really matter compared to someone that might have a smaller cyst, which looks more complex, potentially malignant? Patient's wishes. So if you've got someone that's, I don't know, she's got a dermoid, 6, 7, 8 centimetre dermoid, risk of torsion, but she's, I don't know, she's been born with 1 ovary. Are you going to recommend that she has it removed because you know there's a risk of oophorectomy? It will, you know, affect her chances of fertility and things. So it depends on what the patient wants as well. In general, for simple cysts, so if it's less than 5 centimetres, 50% will resolve spontaneously within 3 cycles. They don't need to be followed up. They don't need to have a scan. But you will see women coming back again and again for a scan, or maybe they might want a scan for reassurance. But our job is to reassure them that actually the cyst will go away and they don't need to use up valuable resources having an unnecessary scan. And if they were to become symptomatic, then they would just need to be referred again. And if they are 50 to 70 millimeters, this I think this was from the Green Top guideline. It suggests rescanning every year. I have to say this isn't what most of us do. If it's bigger than 5 centimeters, it's potentially unlikely to go away by itself. So you can offer them surgical management. Or even an MRI if it's bigger than that. But again, it just depends on what the patient wants. Some patients obviously don't want to have any surgical intervention. They just want to leave things be. So it's reasonable to just see them again in a year's time, but obviously give them the safety netting if they've got any acute severe pain symptoms that they need to be reviewed sooner. You can also aspirate cysts. This isn't something that we do very often. I always think as gynecologists, we barely scan. We've definitely lost this skill, which it is valuable at times. But obviously, because you're only aspirating, the cyst is more likely to come back compared to if you were to remove the cyst wall completely. And randomized controlled trials have shown that aspirating cysts isn't any better than just keeping an eye on the patient. So actually, it makes sense just to observe the patient, unless it's a particularly big cyst. We're talking about simple cysts here, and the patient isn't suitable for surgery, for example, then again, aspiration may have a role. And you can also use, excuse me, so in women who have recurrent functional cysts who keep presenting repeatedly, and usually you see this in more younger adults, so late teens, early 20s, where they have all these recurrent functional cysts, you can offer them the combined pill to hormonally suppress them, and it works quite well, but it's the combined pill, not the progesterone only pill. Next slide. Then obviously the last, the definitive way of managing these patients are doing to remove the cyst. It could be via laparoscopy, laparotomy, depends on the nature of the cyst, how big it is, previous operations, body habitus and things. And you'll find as you progress to ST3, 4, 5, you're on call for gynae, and you're always worried that you're going to get called by the surgeons because they've taken a patient to theatre and they happen to have found a cyst, and then you're like, oh no, we can't touch that, it might be malignant. But actually this fear of it being malignant is unjustified, really. There was a good study by Nezat which showed that the risk of malignancy is very low. Obviously you have to think about the consent side of things before you touch a patient who hasn't been consented for cystectomy and things, but the point is you don't need to be worried about the risk of malignancy. You could do a cystotomy, so make a hole in the cyst, aspirate it, and just leave it at that, but it's obviously more likely to recur. You could cut into the cyst, strip away the cyst wall, which is the commonest thing that we tend to do. Remove the cyst completely. Obviously this is the preferred way with a dermoid cyst, or you can do an oophorectomy. Can't spell there. So obviously it would depend on the size and nature of the cyst, and obviously you would need to have discussed the risk of oophorectomy with the patient before to make sure that she's well counselled. Next one. Okay.
Sorry, yes. Can I just interrupt? In terms of the rules with the size of the cysts,
yeah.
If they have multiple cysts on the same side, but each individual cyst is sort of less than the 50 millimeters, but the combined volume is sort of large, what would you do then?
That's difficult. So what things go through your mind? What are the potential risks of that situation? What might happen?
Well, I guess you worry that it could tort, right? Like if it's
yes. Yeah, so that's one thing that you have to think about. But remember, because the bulk of the ovary goes up, so you're obviously worried about the risk of torsion. But remember, these, on an individual basis, they're small cysts, they're likely to regress. So it also depends on the patient's symptoms. Sometimes if you've just found it incidentally, then it's reasonable, leave it alone, or just rescan them. If they're having intermittent episodes of pain, then yes, you would worry about the risk of torsion, and you could then recommend removing the cysts. So it just depends on how the patient is and how the patient what they want to do as well.
Thanks.
Okay. Right, so it's just the last few slides now, just looking at just a couple of the different scenarios. So you've got a 24-year-old this is your classic line from ED, who's known to gynae because she had a cyst last year. So it obviously means she must have another cyst. So she's developed this acute onset right iliac fossa pain. She had a period about 3 weeks ago. She takes the mini pill. Hasn't been able to do a wee yet, but her bloods are normal. But the pain's quite severe because she's needing Oromorph for the pain. So what are your thoughts? What are your differentials?
You need a pregnancy test.
Absolutely.
Could be an appendix. Probably not with acute pain, but possible.
Yeah, could be. So that's fine. So it was all of the stuff that we said before, you know, dip the wee, make sure she's not pregnant, hasn't got a UTI, make sure there's nothing else going on. And what are you going to do next for her? So hopefully,
think about an ultrasound?
Yes, organise for an ultrasound. So you would have examined her and obviously make sure everything's okay. So do an ultrasound. Right, we can go to the next slide, please. So ultrasound shows, it doesn't show you a rupture, does it? So a lot of the time when you have a history like this, a scan's generally normal. And you think, I don't actually know what's caused your pain. But then you see a bit of free fluid and you think, you've probably had a cyst rupture. Which is really a diagnosis of exclusion. If there's no obvious cyst there, and you know everything looks within normal, and there's a bit of free fluid, it's putting the history together with what you can see on scan, and therefore assuming that there's been a cyst rupture. And this can be quite painful. I'm sure you guys have seen patients who have presented in this way, and the pain can be very severe, lots of peritoneal irritation. It can take a few days for it to settle, and they might well need to have Oromorph for the pain. So that's not out of characteristic for the type of pain that they experience. So cyst rupture is more common in functional cysts. So and it usually just spontaneously or can be secondary to trauma. And spontaneous rupture usually happens on days 20 to 26 of the cycle. The cyst and its contents, so obviously it depends on the size of the cyst and what's inside. So it could just be clear fluid, might be blood, and they might cause different degrees of irritation and pain. Usually you can just manage these patients expectantly, can't you? Just observe them, analgesia, reassure them and let them go home. And if this is someone that gets these episodes recurrently, so again, you may not necessarily see a cyst, but you find this on looks normal, no cyst, but a bit of free fluid, it's safe to assume that she's having recurrent cyst rupture. So for her, you would want to change her if she no contraindications to the combined pill as opposed to the mini pill, because mini pill is not going to help in this situation. Next slide. There's something about hemorrhage. So small hemorrhagic cysts are quite common. The theca interna, if you think back to your anatomy days, they're all very well vascularized, so you can bleed quite a bit sometimes, but it's unusual that it bleeds enough to cause hemorrhagic shock. And again, they usually spontaneously rupture similar times to cyst rupture between 20 and 26 days. Right, next slide. So now you've got a 28-year-old nullip who has a 5-centimetre ovarian cyst and she's 11 weeks pregnant. She presents with a suspected torsion. Histologically, what's the most likeliest type of cyst that she has? What do we think?
Corpus luteum.
Okay, anybody else?
Is it a dermoid?
Dermoid.
It will be a dermoid, yes. And the reason for that is, one, corpus luteums, they can be a significant size, but yeah, they don't generally get to such a big size, such as 5 centimeters, so it's unlikely. But the dermoid cyst, it's one of the commonest type of cysts in that age group, and if you think about all the contents, the contents make it a very heavy cyst, if that makes sense. So the dermoid is more likely to tort, and more often than not, that's what there is. So she's got a dermoid cyst. So next slide. So often it involves the ovary and the tube together, and it's quite a nice picture there. So it's nicely labelled for you. You've got the uterus, you've got the ovary, and you can see that the tube there has torted. And there's a bit of engorgement going on there as well. Usually when you unravel the torsion, the blood, 9 times out of 10, actually everything settles and goes back to normal. And it's quite interesting. Actually, I think the management's on the next slide, so we'll talk about that. But when you've got a mass which is more than 5 centimetres, it's more likely to tort. And we know dermoid cysts aren't cysts which are going to regress by themselves. So if you find someone that has got a dermoid cyst more than 5 centimetres, it's sensible to suggest that they have that removed. 3.5 to 10% of cysts dermoid cysts will undergo torsion, and 25% of adnexal torsions occur in children just because they've got a longer ovarian pedicle, and there's no increased risk in pregnancy. So signs and symptoms. What's oh, I've written it there actually. Usually what you get in women who are experiencing torsion, you have a stepwise increase in their pain. So they'll have episodes of pain, which may last for a varying amount of time, a few hours, maybe a day or two, and then the pain gets better but doesn't go away completely. And then a short while later, a few hours or days later, they'll have similar pain, but it's more severe. So you get this stepwise progression in pain, and that's where your pain history is really important. And then when it's and when it's torted significantly, that's when they'll get this severe pain. What happens if the ovary the ovarian tube remain torted for long enough? What happens?
Necrosis.
Yes, yeah. So it's usually the venous blood supply that gets compromised, but actually that's fine. It doesn't make a significant difference. But if the torsion is significant and for long enough, then arterial supply can get affected, and the mass can undergo necrosis. What happens to the pain then? Pardon?
Does it go away?
Yes, no, the pain settles. I mean, there may still be a bit of background pain, but all of a sudden, well, not sudden, but there won't be any pain. So you have to be suspicious. You have to be suspicious of a torsion. Obviously, necrotic ovaries can be a risk for sepsis. So other things, obviously they might be feeling a bit sick. They may or may not have some bleeding, and if, as I say, if it's significantly torted, they may be unwell. Next slide. So in terms of pregnancy and cysts, obviously, you know, women can have cysts, as in they've got cysts already fall pregnant, and then you find them, and then you'll find them on, oh gosh, sorry. Yes, so usually there's a pre-existing cyst. The patient may or may not know about it. More often than not, they don't know about it, and then they go for their 12-week scan and you find this cyst. But sometimes it could just be corpus luteum, as somebody mentioned. Most cysts will resolve. Only a few will need to have intervention, and most of the cysts are benign. 50% dermoids. I guess that's just representative of the type of cyst in women of childbearing age. If torsion is going to happen, it's usually around mid-trimester during pregnancy, or following delivery, because as the uterus involutes, so the first few days, initial weeks after delivery, then there's more space, if you like, and there's a higher chance of torsion at that point. When's the safest time to operate and remove a cyst in pregnancy?
Second trimester?
Yes, yeah. So around between 18 and 22 weeks or so, that's the best time that's recommended for that. So you remove any cysts if the patient's significantly symptomatic, or obviously if you're worried about the risk of malignancy. If actually the patient's fine, stays well, then they would need to have another scan 4 weeks after delivery to see if it's resolved or not. What if a patient says to you, "Oh, I've got a breech baby, I'm going to have a section, and I happen to have a cyst. Could I have not a breech, sorry, let's just say, oh, I don't know, but she's going to have a cesarean. Oh no, she wants a cesarean for the cyst. What do we think?"
It's definitely not an indication for a cesarean section in itself.
No, it's not. And patients will ask you, to them it seems quite logical. But remember, everything's so much more vascular in pregnancy, you're more likely to bleed. So ideally, you don't want to do these things in pregnancy unless you really have to. If they're having a section for breech, for example, then yes, there's no reason why you can't plan to do them at the same time. In an emergency situation, it's probably not the best time to be doing things like that, unless it obviously looks malignant. Right, I think that's it. The last slide just summarises the few bits. So as we said, ovarian cysts are one of the commonest causes of admission to hospital. Most are benign, will resolve in 2 to 3 cycles. That's really important when you speak to patients in order to reassure them. Obviously, risk of malignancy is higher in menopausal women. Hemorrhage or rupture can be managed conservatively. Torsion would require surgical intervention, but not always. Sometimes you can just detort it and it's fine. More often than not, you need to do a cystectomy, but it's unusual that you have to do an oophorectomy. And as we said, CA125 is of limited use in the acute setting, but may help in the long-term management. So if you suspect malignancy or if it's rapidly rising, as I mentioned before. So for further reading, you've got the Green Top guideline, you've got a TOG article and the strategy module. So the strategy module is actually under gynecological emergencies, in case you wanted to read up any more. So that's it. Thank you very much, Sophie. You did a great job. I'm sorry about all the technical problems today. But that's the end of that session. Any other questions from anyone or any